Good evening. I am Katie Fielding. I am going to be your moderator tonight for our 2025 NACFC Highlight Webinar. We are so glad to have you here with us, and we hope that you're going to learn a lot and have a lot of takeaways this evening. All right, a bit about me. I am a person with CF. I am 44 years old. I have been a research participant for a long time. I love participating in research and contributing to our community in that way. I also do disability advocacy, and I have truly benefited from research such as being on modulators. But there's a whole other life part of me as well. I love to travel. I love to do my career, which is in educational technology, and I have a family that I love being surrounded by. And so we're really excited to be here with you tonight. And so I want to introduce our presenters. Our first presenter will discuss modulators and how they affect the health of people with CF, including infection and inflammation. She will also discuss the next generation of modulators. Our second presenter will discuss aging-related complications such as heart disease and cancer. I now have the pleasure of introducing our panelist tonight. Our first presenter is Dr. Cori Daines. She is a pediatric pulmonologist and division chief of pulmonary and sleep medicine at the University of Arizona College of Medicine. Dr. Daines leads CF clinical research at the Tucson Therapeutics Development Center, a clinical trial site within the Therapeutics Development Network. Our other presenter this evening, Dr. Marty Solomon. He is an adult pulmonologist and clinical translational researcher at the University of Alabama, Birmingham. He directed the UAB Adult CF Center from 2017 to 2022. He then transitioned to the role of associate director of the UAB CF Research Center and co-director of the TDN Center and Clinical Trial Unit. So thank you all for being here. And Cori, it is now your stage.
I really appreciate that, Katie. Let me pull up my slides. Here we go. All right. So I'm really excited to be here today. Thank you so much for joining us and to hear a little bit more about the highlights from the North American Conference this year and the research that was highlighted there. As Katie already suggested, I will have the pleasure of talking a lot about modulators and the research that has been done around modulators in the last 13 years since ivacaftor was first introduced. But we're really going to focus on the last 6 years because it has been the last 6 years since we have had highly effective modulator therapy that has been used in the US by a large portion of people living with cystic fibrosis. So back in 2019 is when this was first introduced, when we first had our introduction of alexacaftor, tezacaftor, ivacaftor, or Trikafta. I'll refer to it as Trikafta. And now our newest triple modulator, the vanzacaftor, tezacaftor, deuterated ivacaftor, or Alyftrek, as I'll refer to it, is also available. Back in 2019, approximately 20% of people at the end of the year were using these highly effective modulators. And now, by the beginning of 2025, we had 76% of people using these highly effective modulators. You'll notice, however, there's still a significant portion of people who either are ineligible because they do not have the right genotypes, or they're ineligible due to age, or they are eligible but are not prescribed. And this is the group that potentially has too many side effects or cannot tolerate modulators. So we still have a group of people who are not using these modulators because they are unable. And most of the research moving forward is really going to be around that group of people and finding the cure for all. But today we're going to talk a little bit about what we've learned in the last 6 years now since modulators have been available in the United States. So we know that the highly effective modulators do wonderful things for our lungs. And we're going to talk a little bit today about what we know about the lungs and what we've learned in the last 6 years. But we're also going to think about the other organ systems that are affected. Since modulators were introduced, there have been several prospective studies looking at people when they start modulators and what happens to them and how it affects not only their lungs, but all of the other organs that where we have CFTR and where we have effects of having cystic fibrosis. What we know about modulators and having so many people on them is that we have a history now. Ivacaftor, our first modulator introduced in 2012, is now available down to 1 month of life, which is really exciting. And we have more than 10 years of experience, even down to the youngest ages with ivacaftor. What we know about Trikafta is that it is available down to the age of 2, and it has done remarkable things for children, for adolescents, and for adults with CF. We know that children as young as 6 who can do lung function for us, that it stabilizes lung function in these young children, that 100% of children who are on Trikafta and have the delta F508 homozygous genotype and a sweat that gets down below 60 have stabilization in their lung function moving forward. And we have the most experience with Trikafta in the 12 and up group. And we know that not only does it stabilize lung function, but it reduces pulmonary exacerbations. And as we'll learn as we move forward, it also has effects on other organ systems. So we have a lot of evidence. Now that we have our triple with the vanzacaftor, tezacaftor, deuterated ivacaftor, we're going to have even more data on how highly effective modulators are able to affect the lung. But one of the things that I want to focus on first, because I think it's top of mind for people that are living with CF, is this concept of, if I do have stabilization of lung function, do I need to keep doing all of the therapies that I've been doing for so long to make sure that I maintain my lung function? Well, one of the most exciting pieces of research that I felt was done in this year's conference was the CF STORM study. Now, many of you are aware of Simplify, which was a study done here in the US a few years ago that looked at people aged 12 and up on highly effective modulators and allowed them to come off their hypertonic saline or their dornase alfa and see how they had. And over a 4-week period of time, it did not seem to negatively affect lung disease or lung function. Well, here, the investigators, Dr. Davies and Dr. Sutherland in the UK, did a registry-wide prospective study where they enrolled individuals through the registry who were at least 6 years of age and had lung function with an FEV1 of at least 40%. And they took individuals and consented them through the registry and then randomized them to either continue all of their mucolytics, meaning their hypertonic saline and their dornase alfa, or stop all of their mucolytics, meaning both their hypertonic saline and their dornase alfa. And then they looked at lung function right at the time they started, and they looked at lung function at 52 weeks or around that window. And in the red boxes here, you can see that there was amazingly absolutely no difference in the lung function after a year in the individuals who stopped their mucolytics. The first box up here that shows a mean difference of 0.97 shows that if they stopped their mucolytics, they had a mean improvement in lung function of 0.45 percentages. And if they continued on their mucolytics, they had a mean decrease of 0.52. Now, that doesn't mean that there was a significant difference in these two groups, but it does mean that there was not a detriment to lung function in individuals who stopped their mucolytics. But what's even more fascinating over on the right side of this slide is that it didn't matter what the lung function was in those individuals or how old they were. People as low as having lung function in the 40 percentile range did not see detriment to their lung function by stopping mucolytics, and children as young as 6 did not see a difference in their lung function. And in fact, in the 6 to 11-year-old group, there was actually an improvement in their lung function if they stopped their mucolytics. Now, please do not take this as medical advice. You should not go and just stop your mucolytics without really talking to your care team and deciding if that is the right path for you. But what this study really did do is show that Simplify was accurate in showing no detriment in lung function, and that was sustained over a period of a full year. And very exciting that it didn't matter how healthy or how young the individual was when they started, they still saw the improvement. So that was very exciting when it comes to lung function and the effects of the highly effective modulators. We also know that people who go on highly effective modulator therapy see a benefit in terms of a decrease in their sweat chloride levels. This has always been thought of as a biomarker. But research done by Dr. Zemenek through a nationwide test shows that as sweat chloride levels drop, that correlates with an increase in lung function, and that the lower the sweat chloride goes, the better the lung function gets. Now, there's certainly some plateau when you hit that sweat chloride of 30, which is normal in normal individuals, but you still see an improvement in lung function as the sweat chlorides continue to decrease. You also see an improvement in exacerbations with lower and lower annual rates of exacerbations as the sweat chloride levels get lower. Now remember this, because it becomes important as we think about optimizing modulator therapy and what we want to do with sweat chloride as a marker to see can we affect the best lung function possible in individuals on highly effective modulator therapy. But thinking about other reasons and other issues in the lungs with people with CF, let's talk a little bit about infection. So in this long-term study, prospective, that was part of the PROMISE study, but also done through Seattle with Dr. Singh, what you see is that people who had Pseudomonas infection had a significant decrease in the bacterial load of Pseudomonas in their lungs shortly after starting modulator therapy. That's a base change that you can see on that red line. And that lower level of Pseudomonas infection was maintained up to a 4.5-year point. What we start to see at about 4 years or 5 years after starting modulators is maybe an inflection that's starting to show an increase in Pseudomonas infection. We haven't seen that necessarily clinically, but boy, we're going to watch out for that because we certainly want to keep an eye on persistent infection. But the other piece here that you see is that there's not a ton of just clearing of Pseudomonas. It doesn't necessarily go away, but it does decrease the bacterial load. So following upon that, Dr. Singh and the group in Seattle did a study where they prospectively looked at 9 individuals with Pseudomonas infection and did bronchoscopy on these adults before and 1 year after starting the modulator therapy. And what they saw is that if the people had Pseudomonas in their lungs before starting highly effective modulator therapy, it was in all lobes, 5 different lobes, all there. After starting modulator therapy, 3 of the 9 individuals completely cleared their Pseudomonas. In the 6 individuals who did not, it was still in every single lobe, all 5 lobes. So it's an all or nothing phenomenon when it comes to Pseudomonas. Either you clear it or you don't. You do see a decrease in the bacterial density. You also see a decrease in inflammation in the lungs. And this was measured, same study, with neutrophil elastase, which again is a biomarker of inflammation. And what you see is there's less neutrophil elastase. But what we know about neutrophil elastase is that it's damaging and that it does over time cause inflammation and hurt the lungs and correlates with lung function decline in the future. So once again, we want to watch individuals, especially those who have persistent Pseudomonas infection, knowing that there's also inflammation. And what does that mean for them in the future? And you will hear more about inflammation from Dr. Solomon when he does his part of the talk. But shifting away from the lungs, let's think about some of our other organs. Let's think about the pancreas. And we know that diabetes is such a burden for individuals living with cystic fibrosis. And so we want to look at more long-term studies saying, what effect does highly effective modulator therapy have on CF-related diabetes? So from the PROMISE study, again, a prospective study looking at people who started on highly effective modulators, we now have 30 months of follow-up. And what we know is that there is a subtle decrease in the fasting glucose and hemoglobin A1Cs in individuals who have diabetes, but there's no change in their diabetic status. They still have the same oral glucose tolerance testing, and they still have diabetes. They have different parameters potentially showing some improvement, but not any resolution of the diabetes. Now, a smaller but more prospective study has been attempted as well. And in this group, we looked ideally at individuals not who already just had CF-related diabetes, but those who had impaired glucose, not full diabetes yet, or had developed diabetes recently within the last 5 years. And in this prospective study, while again we see some decrease in glucose level and some decrease in hemoglobin A1C, there was a slight improvement in the OGTT parameters when they were tested, but still no resolution of diabetes. Now, this makes sense because there's no CFTR, there's nothing that's truly being affected in the endocrine pancreas. And unfortunately, if the exocrine pancreas has damaged the pancreas already, then it's an adverse environment, and diabetes is likely to continue and is likely to be an ongoing problem for individuals with CF, regardless of their modulator status, but something that we will continue to follow and look to see if we can optimize as we move forward. Now, thinking about other organ status, liver disease is a hot topic because 20% of individuals with CF are going to develop some degree of liver disease and liver dysfunction in their lifetime, and a true 5% are going to have pretty significant liver disease as they move on. And so we wanted to look a little bit at whether or not there's any change in liver disease progression on ETI. And we really didn't think so based on the PROMISE study, but this was a study in France where what they looked at instead was hospital discharge diagnoses for people with CF. And when people are admitted to their hospitals and they have a liver complication, such as variceal bleeding or liver failure or cirrhosis, that gets diagnosed, that gets listed as the diagnosis on discharge. Well, this study looked to see whether or not those diagnoses were the same, increasing or decreasing after people started Trikafta. And what you see here in the darker bars on top is that before Trikafta, there was a cumulative increase in liver disease and liver progression over time as people age. In the bottom bar, however, in the lighter color, what you see is a decrease in that liver progression based on these diagnoses on discharge. So what that tells you is it looks like there's a 70% lower incidence of progression of liver disease in people on Trikafta. And that's really good news and something that we can follow to say, it may be protective here of the CFTR in the liver and help prevent progression of liver disease in people with CF. Now, I want to think about that exocrine pancreas because, again, a hot topic is, can we rescue the exocrine pancreas and can we restore function so that we have pancreatic sufficiency again? Well, once again, we have much evidence on ivacaftor and in younger and younger ages. So in studies on ivacaftor in young children, 4 months to 12 months and 12 months to 24 months, we do see an improvement in fecal elastase. And fecal elastase is one of those enzymes that you find in a functional pancreas that is working for enzymes. And in ivacaftor in young ages, it looks like, yes, indeed, we can see some rescue. We don't see so much in lumacaftor, ivacaftor, or Orkambi in the young age group. So starting with the 1-year-olds who can take Orkambi, not so much of a change in pancreatic rescue. We're just starting to get data on the triple for Trikafta, and we have some data in the 2 to 5-year-old range. But what we do know is that in older ages, we can't rescue the pancreas in an adolescent or an adult. But here's the encouraging news. In that 2 to 5-year-old group on Trikafta, we actually saw 8% rescue improvement and return to pancreatic sufficiency in children older than the age of 2. And of course, we hope as we move our highly effective modulators into younger and younger ages that we will see more of this, and will be on the order of what we see in the ivacaftor data of 75 or more % of individuals having true pancreatic sufficiency if it started early enough. So one of the other hot topics that we have is, can we actually dose Trikafta or other modulators at lower doses and still get therapeutic effect? Because many people are using alternate dosing for a variety of reasons, mainly side effects, either mental health or liver side effects, but also because of drug interactions. So work being done in Colorado at Denver through Dr. Nick's group would show that, in fact, on all 3 modulator parts, the exacerbations, tezacaftor, and ivacaftor, that in individuals in the second bar where it says modified, the levels of these various components are still above this little blue bar. You see the little blue bar at the bottom there? That's called the EC50. And what that is the effective concentration. And we think that above the EC50, you get effective drug levels. And it looks like, even on modified doses, that the vast majority of individuals are reaching effective doses for their modulator, and that it should be just fine for them to take a modified dose and still have efficacy. But the other interesting thing for this particular study is to look at the wide variety of dosing. The dosing is the same, but what you see is levels are really significantly different. Well, what does that mean? Well, maybe it will help us to understand there are people who respond very, very specifically to these modulators better than others. And what can we learn from those individuals so that we can make modulator dosing more effective for everyone and get the best effect that we possibly can from it? So we know we can have efficacious dosing even at lower modified doses. Now, I want to show you some data from animals here so that you understand a little bit about where we're headed with rescuing based on Trikafta and triple modulators, highly effective modulators in younger groups. These were ferret and pig models that were treated in utero, so their mothers were treated with ivacaftor from 28 days gestation in the ferret and from 38 days gestation in the pig. And these were individual animals that were G551D homozygote, so ivacaftor would be effective for them. What you see on the very left panel is what wild type pancreas looks like in these 2 animals. What you see in the middle panel is what happens in an animal that is born with CF. And you can see the architecture of their pancreas is not normal. But if you treat them with ivacaftor from in utero, you have preservation and function of those pancreases when those infant animals are born, which is very exciting. Here is something really interesting about the reproductive tract, because we know that men with CF are born without vas deferens functionally because it doesn't form appropriately in utero. Again, same animals, of course, male animals here who were treated with ivacaftor. What you see wild type is the vas deferens that forms in normal animals. And when the G551D, it's absent. It just doesn't form at all. But if we treat with ivacaftor, you see preservation and formation of the vas deferens. So treating in utero may, in fact, actually salvage the reproductive tract as well as the pancreas in not only animals, but in individuals living with CF as well. So real world from a fetal therapy standpoint, and there's a lot of work going on with pregnancies of women living with CF, but also pregnancies of women who are carrying an infant who is going to have CF. And this was a small study done out of France where they looked at 12 pregnancies with women who had children who have modulator eligible CF. And in these groups, they were provided with Trikafta starting at 28 weeks gestation. And what happened is that 8 of those pregnancies prenatally by ultrasound were diagnosed as having meconium ileus. And in those infants, 6 of the 8 actually reversed their meconium ileus and were born without it. The other 4 pregnancies that did not have meconium ileus were normal pregnancies, and the babies were born without meconium ileus or complication. Importantly, those babies did not have abnormal liver tests or cataracts when they were born, and so they didn't see side effects from the highly effective modulator therapy. But it did not preserve pancreatic sufficiency or male infertility in these pregnancies started at 28 weeks of gestation. So more work to come here. And there is new work being done prospectively to look at fetal therapy to try to affect CF in the fetus. Now I'm going to take you back to the sweat chlorides, and this is really to think about where are we headed for CF modulators and what's next on the horizon. So we know already from Vertex data and from published work by Dr. Keating that the vanzacaftor, tezacaftor, deuterated ivacaftor, Alyftrek actually affects sweat chloride levels and brings them lower than Trikafta alone. And what we can see over here on the right-hand side is that children were very responsive to this, and a full 95% of children on the Alyftrek got their sweats below 60, and a full 53% of children got to normal sweat levels below 30%, which would make us believe better lung function in the long run, fewer complications. So this is very exciting. Can we affect the modulator therapies to make it so that we actually receive normal function of a CFTR? Well, now this is Vertex data, and this is what's coming, guys. This is the next generation of modulators that will be coming from Vertex. And what we see on this slide is CFTR function. So we're looking at what percentage of CFTR of the chloride channels can we restore. And what we know is that on Trikafta, we get about 50 to 60% restoration of lung function. That's good, but it's not normal. We know that carriers, so people living with a carrier or just carriers, get 80 to 90% function. So we want to hit normal. On the vanzacaftor triple, the Alyftrek, we're getting close to that 80% mark of restoration of chloride channel function, which is exciting. But the next generation of Vertex products, the VX828 products, are coming and about to enter clinical trials. Right now, it's in a dish, but what we see is that dual therapy actually restores CFTR function to normal levels, and triple takes us fully into the normal range in CFTR function. So very exciting that we can afford even more function from modulators in the future, and we're looking forward to those clinical trials that will be coming shortly so that we can see what else we can achieve here. But one last thought about modulators. I want to take you to a little bit of a molecular level. Over here on the right-hand side is the structure of the chloride channel. It's the cell membrane on top, and that's where the gate is. And those parts of the chloride channel are obviously really important. That's where it opens and closes. All the part below the cell membrane is kind of the anchoring protein. And what's important here is that the delta F508 mutation is actually down in the anchoring part of the protein. There's a green arrow to where it is. It's within the NBD region. That's the nucleotide binding fold region number 1. And that's where the mutation is. But you know what's fascinating is that the actual molecules in all of the Vertex products in the modulators don't bind here. They bind in the part that's in the cell membrane. So how does that work? Well, it actually stabilizes the chloride channel, and so it makes it effective. But what if we could actually get a modulator that binds down inside this binding region where the delta F actually is? Well, that's what Sionna Therapeutics is coming up with. It's a modulator. You'll see the various terms of their different modulators that bind in this bottom part of the molecule and stabilize it further. And what they found in Petri dishes, again, is that their molecule alone, without anything else, actually restores chloride channel function to near Trikafta levels. But in combination with a highly effective modulator therapy like Trikafta, you can restore chloride function to those normal levels. And so this will be very exciting for us, also coming soon for clinical trials, and will be an important part of how we see what we can affect with modulator therapy. And on those exciting notes, I'm going to finish my part of the presentation and turn it over to my colleague, Dr. Marty Solomon, who's going to talk more about aging with CF and inflammation with CF and where we need to go now that we have a population that's living longer and healthier lives.
Well, thank you, Cori. I'm going to pull up the next part of the presentation, and I appreciate the kind introduction and the opportunity to speak to you all tonight. We're the second plenary of the North American CF Conference really highlighted some future directions of research and understandings about the overall clinical entity of CF. So I'm going to endeavor to highlight some of that and try to bring it all home in the therapeutic space in the next few minutes. These are my disclosures. And so I want to say, first of all, that we're truly in a unique time, as Cori highlighted, in CF. The survival and quality of life has dramatically improved for many people, but not all, and it's variable amongst those who are better. So we understand that the disease state is variable now, and it's not perfect, but there's been a lot of successes, as she's highlighted, and a lot more to understand. But especially with success in survival, people are going to live longer. We have to rethink aspects of the disease state, especially in terms of how will CF patients and people with CF uniquely age, and will there be aspects of the disease that emerge as an older population of people with CF live to those ages. And symptoms and aspects of the disease that are likely to continue or emerge include cancer risk, pain syndromes, and other aspects of inflammation that we'll talk a bit about today in these highlights. So we know that the disease of CF changes throughout life, and diagrams that describe aspects of the disease as we go through birth, childhood, and adulthood typically have had what we think of as the end-stage cystic fibrosis as listed as disease manifestations. But as people age with restored CFTR function, which we hope will be achieved for everyone with cystic fibrosis, that disease state is going to look different. So this far right graph here that shows aspects of the disease that we think of as sort of adult cystic fibrosis, that's going to look different in future years. And we have to understand, A, what that's going to look like, and B, how do we understand what to do with it to make people live the best lives they can throughout their lifespan. And so some of those changes that we may see in that disease manifestation graph may be persistent lung disease. Bronchiectasis, the remodeling of the airways, is probably going to be persistent for many people, and so will the remodeling of the sinuses. We know, as we discussed, and it's been learned through PROMISE and other studies looking at the long-term effects of modulators, there will be persistent bone and skeletal abnormalities with pain syndromes possible related to those. We know there's going to be a changing body composition we'll talk about in a few moments also. And with persistent and long-standing diabetes, which goes along with CF and which is not fully corrected by CFTR modulators, coupled with ongoing inflammation, which we'll talk about in a few moments, that creates a risk state for kidney disease and cardiovascular disease and cerebrovascular disease, causing strokes in patients as they age. And so those are things we know we're going to have to look out for. So let's think about accelerated aging. And accelerated aging, which has been known to be the case in cystic fibrosis, even in people that are or aren't treated with CFTR modulators, is really due to a dysregulation of our immune system and persistent and excessive inflammation. And so when those two don't talk together, which is a target for us, which we want to target to slow down aging, there are many things that can emerge. And we know that inflammation and dysregulated immunity across the spectrum of humans with disease is known to cause heart disease, be associated with cancer, neurodegeneration, and skeletal degeneration, leading to pain syndromes and disorders of the immune system as people age. And so those are issues that we know we can expect to happen for people with cystic fibrosis as they age, especially with ongoing inflammation, and things we'll have to target to prevent that. As Cori mentioned earlier, the key mediators of inflammation are reduced in cystic fibrosis in patients that are treated with Trikafta or other triple combination therapies, but not to normal levels. So this is data from the PROMISE study, and a study that I was happy to participate in, which we show that in the lungs especially, the levels of key inflammatory mediators like neutrophil elastase and other pro-inflammatory mediators are reduced. But as you can see, they're not reduced down to normal. Those boxes, those blue boxes at the bottom of the graphs that we added in, show where the normal levels of those inflammation would be for people that don't have disease states. So what we can see is there's a persistent inflammation well above normal, but it is significantly improved. So we're in a situation where across the body, we will have persistent inflammation that's better with people that are on effective modulators, but not down to the normal levels. So there's going to be an ongoing persistent inflammation and dysregulation of the immune system that's going to happen for people as people age with cystic fibrosis. Now, in addition, we know there's evidence of accelerated aging in CF. This is a busy slide that comes from a paper summarizing all the different factors that result in accelerated aging. And the purpose of this slide is to tell us that we know a lot, but we don't know yet how to treat these aspects of disease. So many of these things are very relatively new discoveries that we know accelerate aging and play a factor in many disease states, but certainly cystic fibrosis. And so these are areas that we think will be pathways or metabolic or other types of pathways at which we can target for future therapeutics and things to be looking at on the long-term horizon. Now, aging-related complications are also accelerated in cystic fibrosis, which provides further evidence that aging is accelerated in CF and it affects the disease state. So what you can see is that patients that are pre-transplant and post-transplant have increased risks of cardiovascular events, chronic kidney disease, symptomatic kidney stones, and cancer compared to others. And compared to the norms in patients both pre or post lung transplant in this study, we see that compared to people without CF, that these outcomes happen somewhat significantly earlier in both of these states in cystic fibrosis, indicating that aging is accelerated and earlier in the disease state and also is more advanced in the disease state as well compared to people without cystic fibrosis. Now, we also know that CFTR modulators can impact things positively, but there are some negatives that come along with taking these medications as well. One is an emerging understanding that people may be developing more levels of hypertension, which is a predisposing condition for the development of more severe cardiovascular disease. So what we see is that compared to patients who were treated for CF 20 years ago, now more patients are overweight, and this is paired with more hypertension, which comes along with that. That will lead to more risk for cardiovascular disease, especially in the setting of having increased risk for accelerated aging and ongoing inflammation with the disease state. Another area we'll have to look out for. So what can we do to reduce inflammation? Well, there's a lot of healthy lifestyle things we can do. We can optimize CFTR restoration, but we'll have to learn more about that. And if you're interested in that, I would invite you to review the recordings of Symposium 2, which discusses this in more detail. In addition to that, to cardiovascular risk, pain is prevalent in cystic fibrosis. Compared to people without CF, 70% of people report chronic or recurrent pain from lots of different sources, as shown in the graph on the right. And so what that tells us is that's a limiter for optimizing the overall living with the disease condition. And in addition, cancer risk is increased in cystic fibrosis. We know that certain cancers are more prevalent but some we don't fully understand because we have not had enough data to understand that. But regardless, we know there's an increased risk of GI cancers and lung and testicular cancer in people with cystic fibrosis. That's already known data. So we can presume there will be risks for other cancers as well due to these dysregulated immune system and inflammation that's present. And CFTR, unless it's functioning fully normally, is what's called a tumor suppressor gene. So this is an interesting slide that came from one of the plenaries that talks about various mechanisms that are secondary to CFTR, the main protein responsible for CF. And when it's not working, many of the things that lead to the propensity for cancer are enhanced at an earlier span of life. And so we know that because of the risk of GI cancers, we can presume that will happen in other parts of the body. And so there will be increased risk for cancer we'll have to target as a new area for understanding research and therapeutics. So I want to turn to these two comparator graphs to help us think about the situation of a changing disease state. So if this graph on the left shows patients who are untreated with CF, the kind of classic state we thought about before, many of the complications of the disease are going to look like things we can see. So in this example of an iceberg, most of the iceberg is out of the water. So we can anticipate what that's going to look like over time and anticipate what complications people will have. However, as I hope I've made clear to you guys today, and what was a big highlight of the NACFC this year is that CF with people with highly effective modulators may in fact look a lot different. And there may be a lot of risks and challenges for their health, but many of those may lie under the surface of the water. So that iceberg may look a little less daunting on the surface now, but underlying that are many, many complications that may arise over time, especially as people age. So it's sort of a challenge with the success we've developed. And so that's what we want to target and make things better for people. So what can we do about these emerging challenges? Well, there's several things we can do. One is prevention. Doing cancer screening, things that are already known, lipid assessment, screening for diabetes, and recognizing the need to prevent rather than react to disease states. The second is promote healthy living, treating the whole person with healthy, balanced diet, with exercise and rehabilitation, and treat aspects of the disease with intention and safety. The other is treating aspects of the disease safely so that we don't make things worse by trying to make them better. And that's understanding about the disease state itself and understanding how the disease state can be treated with the most safe and the most effective drugs. And finally is research, both understanding the aging process and what leads to that in a more fully formed way than we have done before, and then further modifying the disease state to reduce the consequences of it, including inflammation, essentially treating the pieces. And so this puzzle will tell us why. And I'm going to end with talking about the often discussed CF therapeutics pipeline and what's emerging to think about aspects of the disease state that we're thinking as a summary. So there are several areas in the CF pipeline that were not so much reported out at the CF conference this year, but will be in future. So this is a looking forward thing you can keep as a feather in your cap for future areas of research that will emerge. One is repairing the CFTR gene, and that's really the area of gene and nucleic acid therapy. So there are a number of results expected in the next 12 to 24 months, including aspects of mRNA therapies, adding functioning CFTR through true gene addition therapy, the correction of splice sense with molecules like antisense oligonucleotides, which are currently in trials, and then the concept of editing and fixing the gene variant, which is a future area we hope to pursue and which is in preclinical development right now. In addition, as Cori highlighted earlier, there's really a lot more to do with restoring CFTR function. And we know that new drugs will add on to what's been achieved with Trikafta or Alyftrek to boost CFTR function, including new modulators, which may stabilize or enhance the protein function, new correctors, which she discussed earlier, and then the class of agents called read-through agents for patients that have class 1 or premature termination codon variants, such as the G542X variant of CFTR. In addition, we know, and maybe even more importantly, we've learned that treating aspects of the disease, especially inflammation and infection, are going to persist as a target for CF drug development and be a very important in modulating the disease as we go along with the lifespan of the condition. So other ion channels that affect mucus clearance are being targeted as future therapeutics for mucus clearance. In addition, new anti-inflammatories, especially very exciting work in which neutrophil elastase inhibitors, which are either currently in phase 3 trials or have been recently approved for bronchiectasis as a whole, including the drug called brensocatib, are in study or out to patients right now. And finally, there are a lot of new approaches to anti-infectives. As we saw earlier with the PROMISE data, infections will persist with cystic fibrosis, but new novel anti-infectives are on the horizon, including phage therapy, which are primordial viruses that primarily and predominantly attack bacteria rather than human cells. Methods to disrupt the cooperation of Pseudomonas, that includes biofilms, metabolics, which include IV gallium, other therapies which preferentially kill the metabolics and metabolism of bacteria over our cells, and then new formulations of traditional and inhaled antibiotics to make sure that we have optimal therapies for those as well. And so with that, I'm going to conclude, and we'll introduce our Q&A, and I'll bring Cori back on.
Thank you so much, Dr. Solomon, Marty, Dr. Daines, Cori. There's both so much information that you guys shared today. But before we get into the Q&A, I have one little thing to share with everyone. And that is our pretty new resource from the foundation. And that is Katie Howe. She is the foundation's Clinical Trial Navigator. She can answer your questions, help you find clinical trials you're eligible for, and facilitate contact with a research site. So if you're interested in being part of some of this research in the future, she is a great resource to reach out to. You can email her at trialnavigator@cff.org or fill out a form on our website. The website will be put in the chat. So
I want to second that. Katie has been a great resource. She's on our regional calls very often, and she's a frequent emailer to ourselves and my lead coordinators, because we have a very big clinical trial enrolling site. And so she is great, and she knows all things about clinical trials. So please, please, please use the resource. It is there for you guys.
Awesome. All right, let's get into the Q&A. The first question we have is, what do you think are the most promising new advances for CF patients coming in the next couple years? What's on the horizon? Either one of you.
Cori, should I start, or you want to lead off?
And then I'll fill in after. Go
Sure.
ahead.
I mean, my primary area of research in the CF space is restoration of CFTR function. I think small molecules and gene therapies that optimize that for everyone with CF, it's probably going to take a combined effort of small molecules for some people, gene therapies for some, and a combination of those, maybe even all of those for everyone to get the optimal CFTR function. But I think we will see in the next few years that we can restore near normal levels of CFTR function for almost everyone with CF. Now, it may not be easy, but I think that is a goal that we're trying to achieve, and we know that will create an even better level of health and probably further prevent some of these complications we talked about today and further optimize the disease state.
I think Marty is absolutely right, and we're close. I think a lot of the new therapies, modulators, and even optimizing the ones that already exist is going to be right on the horizon for people who are eligible for highly effective modulator therapy. I think that a lot of the gene therapy that Marty has talked about, it's exciting, and we're going to have some nice first and second level results coming. It's going to take a little longer for that. And so I think there are other aspects. I think we will have anti-inflammatory therapy, as Marty has spoken to, that will help with the neutrophil elastase and the ongoing damage in the lungs for damage that's already been done and will continue to go on for people. And I think that will happen in the next couple of years and will be a nice additive for individuals with CF.
And in fact, to add to that, the anti-inflammatory, the brensocatib molecule, was not per se approved for CF, but a very similar drug is actually being tested in a large population of CF people right now in a phase 3 trial. So we likely will have at least the opportunity for an approval of a drug. I can't guarantee it'll be approved, but likely the opportunity for approval of a drug in the next couple of years that will have had CF patients as part of the trial and presumably part of the labeling for that, at least in the US.
I agree. And then the last little piece, as a plug as the pediatrician in the room, these highly effective modulators are getting younger and younger and younger, and we really are looking at pregnant women now in terms of trying to prevent and start from scratch. And that's going to be exciting, and I think we're going to have approvals for the 1 to 2 year olds, for the Trikafta very shortly, and moving through with the Alyftrek as well, and then, hopefully all the way down.
That's all super exciting. I just want to remind everyone in the audience, if you do have a question, please use the Q&A at the bottom of your screen. We're going to jump into the next question.
Sure.
What, if anything, is the outlook regarding gene therapies for patients that have had transplant and can't take modulators?
It's a great question. It's a little bit more difficult. So I think what you should know is that the current status of gene therapies is they're all being targeted towards lung. Now, why is that? It's not because we're trying to leave out the rest of the organ systems. It's just that the people that don't have access to modulators because they either can't tolerate or aren't eligible because of their gene variants, the lung is still their biggest problem, right? As it has been with CF. This is exactly an example of the changing look of CF as different people have different therapies. The people that don't have access to modulators, their disease state still looks like I could get very sick or die from lung disease. So the targets right now are the lung because that's the area that we're most worried about. The good news is what we're learning about honing vectors, which is what delivers the gene product to the lungs or wherever. We're learning a lot about how that works in the lung and CF. And so we'll be able to use some of those vectors and hone them to other parts of the body and presumptively work on other aspects of the disease. The pancreas will be very difficult because it's very scarred, even early in life. But the GI tract may be very targetable, for instance, or other aspects of these may be very targetable. So I think the point of that is why I'm saying that is transplant patients don't have missing CFTR in their lungs anymore because they've been transplanted. So it may be a little bit of time before we have gene therapy to that aspect of the disease, but there could be sinus gene therapy used, or there could be GI gene therapy as we come along. But I don't think transplant patients will be as early in the process because of the target right now being focused on lung because of the overwhelming need for that for people that aren't modulator eligible.
All right, actually, Marty, the next question's for you, and it's something that pretty interests me because I've done a couple phase 1 phage therapy studies. And so is phage therapy for an option for MAC, Mycobacterium avium complex infections? And I used to have that, so I want to know more too.
Great. So it's a great question. So phage, as I introduced briefly earlier, are essentially a primordial type of virus. They're actually the most prevalent semi-living thing that exists in the known universe is phages. They're more prevalent than other viruses. They're more prevalent than bacteria and other types of living cells. So, and they can be targeted towards the killing of bacteria if they're modified slightly. And there are some naturally occurring phages that do that. And so they're thought to be very effective because they should not have any effect on human cells, which are a totally different type of cell than cells that bacteria have. Now, the initial targets for most phage have been infections like Pseudomonas because those cause a lot of havoc. But more chronic infections like mycobacterial infections like MAC, commonly called MAC, is one of the most common one of those. They also form aspects of what we call biofilms, and they form cooperativity, and they divide in those biofilms just like Pseudomonas does. And so that's a perfect setup for a viral treatment like a phage. And so actually there is an active trial looking at patients that have persistent MAC infection to use phage, and there are other commercial products being developed to target phage for NTM. So the trial called the PostAMP trial is looking at actually an intravenous phage administration, but there are others which are coming to bear in the future for trials that will be inhalational phages, just like it's been used for Pseudomonas in various development programs right now.
Awesome. All right, another topic of interest from the audience is CF liver disease, particularly cirrhosis. It doesn't get talked about a lot. Other than the research that Dr. Daines mentioned in her talk, Do you guys know if there's any other updates on CF-related liver disease?
Marty, do you have
I'm happy to start the answer on that one. So Cori presented a study from France about an observational study. The promise and other studies that have been observing patients for a long time post-modulator have looked at this. And I can tell you that we are preparing a manuscript from one of our sub-studies right now that does suggest that early liver disease stabilizes and in some instances improves. Now, established cirrhotic liver disease is not going to get better. The problem with it is not the CFTR restoration, it's the remodeling of the organ, right? So cirrhosis is another word for scarring, just like we have with the pancreas. The cystic fibrosis that we hear with CF is actually because of the description of the pancreas way back almost 100 years ago now. When you have scarring and fibrosis, that's not going to go away. Now, it may be able to be made better by treating the underlying kind of thing that fuels the fire, the inflammation around it, and stabilized. But we're not going to see that patients are going to have reversal of cirrhosis with modulators, doesn't look like. But early disease may have improvements and reversal in some instances. So I think that in itself is encouraging for the next generation of people. We may be able to sort of halt that, just like we may be able to halt pancreatic disease by early enough treatments, especially the very initiation of life and whatnot. So that's, I think, something to look forward to, but we don't have a full answer on that yet, but we will in the future, we think.
Yeah, I think we will. And I also, I think that that with the liver disease, one other thing to say is that we know that modulators affect the liver and that there are people who have side effects from the modulators on the liver. But in general, those are transient. The elevation of liver enzymes, at least as far as we can see, does not typically then lead to cirrhosis, at least at like sort of the 6-year mark, which is where we are right now. There is true drug-induced liver injury that can happen with highly effective modulator therapy, and it's really important to get your LFTs checked while you're on modulators and to follow that prospectively, because it doesn't have to happen in the first year. And so trying to avoid the liver piece with your highly effective modulators, while we think it happens in most cases, we want to be careful.
It's probably an area where understanding dose modifications is very important because you may be able to dose modify and get that to where it's not such a damaging inflammation and still be able to take the therapies, but not have to stop fully and get some benefit of modulators without having so much liver inflammation and injury.
Exactly.
All right. Well, while we're on modulators, we know some people have had a hard time tolerating them because of mental health as side effects. So what is being done or can be done to study how modulators are affecting the brain and mental health?
At this point, we're doing a lot of prospective sort of observational trials to figure that out. There's a lovely trial going on called Retrial, which many people on this call, I'm sure, are aware of, where we took individuals who stopped or modified doses of Trikafta because of their mental health findings and have now switched to the Alyftrek to see if there are the similar findings. And one of the nice aspects of that trial is they're actually sort of doing some mental health cognitive testing to sort of try to understand a little bit more about the pathways and what's actually happening when there are mental health side effects in individuals who are starting on the modulators. I know there's a question in the chat about, are the mental health side effects the same? I don't think we know that yet. Yeah. I think we're afraid that it may be that case, but we're going to try to follow that prospectively, especially with the onset of Alyftrek, to see what we can find out. In terms of actual brain research, Marty?
I want to just amplify that and say that, the first step in understanding what to research is understanding the problem fully. And when we say something like neurocognitive or neuropsychiatric side effects, that can be anywhere from I'm a little bit fuzzy sometimes to I have full-on psychosis developing. And those are two vastly different things. The brain biology of those is different. And it may all be tied to CFTR, but we have to understand how much of that is normal disease state, normal people having development of those kind of things versus the treatment. And that's not to defend the modulators. It's just to say we have to know what really we're dealing with. And so it takes a little bit of time for understanding what exactly the full extent of the problem is and how tight the association is. And once that's better established, which I think it's still in the phases of doing that, then we can say, all right, what's the key biology? Because we know a lot about brain biology that we didn't know some years ago. What's the key biology we should target to think about therapeutics that might already exist or that just need to have some further development to get there?
Great. Yeah, I know it's affecting enough people that it really matters. So looking for more on that. Kind of related, based on the side effects observed in people on Trikafta, does it appear as though there's a prevalence of side effects is persistent in the early studies of the two V modulators you showed in the bar graph earlier? Are there any studies on the efficacy of a modified or lower dosage for those side effects?
Think that's retrial. That's one of the studies that's going to help us answer that. And there's others happening too in the US and elsewhere about dose modifications. I think that'll be something you'll see reports out in the next couple of iterations of NACFC and European CF conference, that kind of thing. So be on the lookout because I think we'll know more. I think the answer is yes. It's just got to have some more research.
And and Dr. Nick's group in Colorado that has looked at sort of the levels that you achieve with the various components of the modulator, they are expanding that into the V modulators as well to really look at those components and see, where might be the problem and where can we lower the doses and to what level. I think that in the early phase trials of the new Vertex products, the 828, that's what the dose adjustment and the dosing is all about, is figuring out what is the optimal dose with the fewest side effects it's going to achieve the most. And we're so early in there that, we have time to figure that out.
Right.
All right, here's one that I definitely have experienced in my own life. What research is being done to better detect or diagnose infection for those of us that now can't get sputum up? We go to clinic and now we can't fill that cup. We're getting like micro sputums. Like, what's the word on that?
There are a number of trials that are getting started within the TDN that Katie, if you want to participate, where they're looking at alternative ways. We're looking at breath condensate, so whether or not we can blow our breath into a balloon and collect the molecules that are in our breath, and whether they can help you detect the various molecules there, and looking at different methods of obtaining samples that we're not getting from sputum as well. Marty?
Yeah, I agree. Yeah, one thing that my other role in this world is being an ICU doctor. And so if we don't know where infection is coming from, we go sample lots of different fluids. And so there's a lot of different fluids you could look at. Actually, a lot of proteins that are specific for certain bacteria come through the urine because they're excreted there. And so urine is a sample that's been looked at. Lots of labs look at urine sources. Blood would be the easiest to get, actually, because you could just get a blood sample, getting other blood draws for other things. And then the problem is specificity for the lung or other infection sources if you get it from the blood. And so I think that's one of the areas we have to learn about. The detection methods are there. It's a matter of what the right sampling place is, I think, is a big question. And targeting that to say, all right, we know that sampling from this area that's distal to the lung means it's a lung infection, and we can trust that with certainty, and that just requires some research. So, but the good news is a lot of the pieces are there. It's just a matter of putting them all together.
Yeah, and understanding thresholds and what level of
absolutely
bacterial detection means that there's truly infection versus something that's not important.
I just want a lineup of dogs when I go to clinic, and I just breathe on them, and they detect. They're like sensing dogs that have been trained for that bacteria. All right, last question.
It's funny, Katie, that's actually has been looked at in certain infection diseases. That is, I don't know about CF, but it has actually been looked at. It's not as crazy as it sounds.
No, so, I know. I knew it had. So I was like, I just want that to be like standard at clinic. Just a bunch of gold. Yeah. All right.
Yeah, very cute. Yeah, golden doodles, right? Doing it. Yeah, exactly.
All right. Last question of the night. Are there any updates to the research on ongoing CFRD trials? Although the data regarding GLP-1 has been limited, is there any consideration of using GLP-1s for CFRD, maybe even microdosing?
Marty, you're the adult physician.
Yeah. So, there's two areas that you can do research, you can do clinical care. And one is strictly what's in the trials. The other is let's try something and see how it works. I know that many endocrinologists use GLP-1s at microdose, or even if patients are beginning to have weight gain, which has been reported, we discussed earlier, and other cardiovascular risks are emerging with modulators as people gain some weight, which is a good thing. They're gaining weight, but it can be too much, right, for the body to overcome. the GLP-1s are really, they're in the obesity world, they're one of the kind of, we consider miracles, kind of like modulators are right now, right? And so there's a lot of thought. They also have a pretty potent anti-inflammatory property that's emerging with people that have, especially that are diabetic. So not to say they're not therapeutic now. There's not been a large scale CF trial, but there probably will be the one that comes up over time as those get, the problem is they're expensive, right? So, what to do with that. I think the other thing is that we're going to have other therapeutics, as I outlined briefly earlier, that may hone the best insulin dosing or hone the best other medications to understand what we need to do with insulin, with glucose control to optimize. The other thing interesting about CF diabetes, though, is that we don't know as you get older and have long-standing diabetes with CF if it's the same as having type 2 diabetes. That's the common middle-aged and older person diabetes. It develops commonly in people that are a bit overweight, that may have, we call the metabolic syndrome. We don't know if that's the same kind of diabetes and has the same consequences. So understanding what we're targeting will tell us what we need to do as far as therapeutics. If it's a really inflammatory type diabetes like type 2 is, we may need to have a GLP-1 because it has those properties. If it's more of a glucose control, that kind of thing, it may need to be the best, easiest insulin that doesn't require so much stuff to do all day with it, right? So I think that's what we have to learn. And there's studies like the Spectrum study, the bionic pancreas study, that are going to give us more information about that in CF specifically, and haven't really been conducted to that extent to date. So I think we're going to learn more about it from those.
Right.
Again, another define the problem kind of issue. So
exactly. Both of those are for individuals who are potentially on this call that are adults living with diabetes, and would be good trials to get into to understand a little bit more.
Awesome. Well, thank you so much, Dr. Daines and Dr. Somlin. Your information has been wonderful tonight.